first off, thank you for having us here. I know Rebecca Rainsberger is the one that originally arranged this, that I've been part of her group. She has an Aging Smart group that she's been part of the harbor here for a long time, probably about 10 years. And then she's part of a national group, it's National Aging in Place group. And part of our mission and what we'd like to do is to go out and do educational offerings to the community. And our goal is, we think educational is powerful for everybody. Did you want me to?
You don't have to, I'm just going to set it right now.
Okay. And so what I'm covering today, they've asked me to cover is hospice services. And I'm here to alleviate any myths and answer any questions that you guys may have. That I am part of one group, which one thing that's a little newer, not newer, but Washington State, most people think with hospice that, it's just one agency, that it's just your healthcare agency, it's just through Multicare or Franciscan or those types of things. Well, Washington is a certificate of need, that's a little bit in the weeds, but they have opened up how many people can do hospice now. So in order to do a business, you have to go through the state. It's a very long process. It took us about 2 to 3 years. Every county we have to be designated in. So we've been in Pierce County for almost 2 years now. Continuum is the name of my organization. So you'll see that there's a lot more individual ones that are out there versus even 10 years ago. People are like, now I get it, that, it's not just one umbrella. So the nice thing about that is that now with hospice agencies, because there's more of them, that the consumers are winning. The expectations are becoming higher and what we can provide. Each person is providing a little bit different services, and so, like I said, as a consumer, you're benefiting versus just having one type of style. And they were backlogged for 2 to 3 months, and you can't do that with hospice. Today I'm working on one. I was going to admit tomorrow, and we're trying to do it today because it's, so it's a need-based service. So I'm here to talk about hospice. I'm with Continuum, which is just one of the agencies. So, but I'm just talking in general. Hospice is a Medicare funded benefit. So everybody, Medicare or Medicaid, covers it 100%. And so I always like to let people know. So everything I described today is covered by insurance. And what hospice is, it's palliative, it's not curative. When people decide that they want to or consider hospice, it's when you get to that point and say, I just want the best quality of life. I don't want to continue going to the doctor or the hospital, no more tests and treatments. I just want to have the best quality of life till the end of life now. And when you get to that point, that's when hospice is a good consideration. And we focus on comfort and managing stress is what our focus is. And much to people's disbelief is that it doesn't hasten death, actually, when you're on hospice. Actually, we find oftentimes it's the opposite, that a lot of people are a lot more relieved when you don't have anxiety and pain, then oftentimes your quality and type of life you have is better. So to be eligible for hospice, you do have to have a 6-month prognosis based on your current disease, that your family has, or your doctor has to write that, and then also not to be seeking that treatment. So you can't be, so if you're on chemo or something and even just an ongoing one, you wouldn't have to be able to continue that type of treatment. So it's when you decide that you don't want that in. The most common hospice diagnoses are cancer, heart disease, dementias, respiratory illness, and stroke. So what hospice includes, so when you consider hospice, what it includes is a team of people that will be coming wherever you live. So it could be in your home, it could be in an assisted living, memory care, adult family home. Wherever somebody is where hospice is. Or it could be a van in a driveway, if we've done it before. So it's wherever they're calling home. And we come and we have a team of people that would be doing visits. The team consists of a nurse, they're the primary case manager, point person. They're coming out, checking vitals, making sure that you have the supplies you need, you have the medication, and whoever's caring for them has the training that they need. Then we also have home health aides that will be coming out. And just to give you an idea, all of our visits are about 30 to 90 minutes within our organization, so all of them have a visit. They're just short visits. Our aide is a bath aide, primarily taking care of their personal care. Our agency, we do it 2 to 5 times a week, so everybody kind of varies as far as how often that is. But it's for their personal care. We also have social workers that are available, and that's for paperwork, as well as emotional support for everybody that's involved. And when I say everybody, it's any family member, because you find some people are estranged or might be out of the area. We're here to support them as well. And everybody might be on a different level, and that's okay. That's what our team is here for. And same thing with if they're in an assisted living or adult family home, we're also here to support the team that's there. You know, the caregivers that are within their communities. We also have spiritual care counselors. Our agency is non-denominational, and so we meet people wherever they are spiritually, so we find out about that. And so they can do visits as well. We can either do visits, or people like they're Catholic, we can make arranged visits as well, just for like that last communion for them as well. And then also we have, with our agency, we have board certified music therapists. That's part of our team, which is a little unique, but otherwise the social work, the nurse, the bath aide, the spiritual care are all included, as well as a physician that's available 24 hours a day to access.
What was the last team member you mentioned? After spiritual care, there was one other person?
On our team, we have...
I'm so sorry.
We have board certified music therapists as part of our team. It's a little unique, but it's
Board certified.
music therapist. So a lot of places have volunteer music, harpists or musicians that do go in. Our team, that they find it's very, that music is so therapeutic, they're actually therapists. They're going in there. Some of them are actually they're creating songs for families, and they're finding out where they are and what they can, give them peace. And sometimes it's even doing, collaborating with our, spiritual care and doing a visit as well. So that's part of our team though, but that's a little unique.
Yeah, cool.
But otherwise the rest are all mandatory. So you see these two people are there to visit. All of us also have a nurse triage line. They can call 24 hours a day. So that's how we keep people in the home versus calling 911, that they can call our triage line. We try and facilitate through that, knowing what kind of medications and support they have. If we're not able to resolve it, we send a nurse out at any time. So our goal is that it's not 911, it's our nurses coming out and being able to resolve what's going on with them. So that's kind of an overview of our team. What hospice also includes is durable medical equipment. So the hospital bed, the table, the oxygen, wheelchair, walker, shower chair, all of that is included, as well as personal items. So incontinence supplies, gloves, wipes, briefs, lotions, shampoos is included under hospice. And then also medications. And our medications focus on pain, anxiety, constipation, and nausea. So, and again, to step back, that this is all covered under insurance. So what we find is that people, once they hear about this and say, it's, when you decide to choose hospice, all you're saying is, at this time, you don't want treatment, and we could really benefit from this free, paid for, extra support. And it's, good for the caregivers, the families, as well as the patient that's going through it. So that's kind of an overview of hospice. When somebody passes and they're in the home, they contact us. It's not 911 coming in. It's our nurses coming out and pronouncing and then honoring all of their wishes too. So does anybody have any questions about hospice? I can help answer. It's kind of an overview, make sure I didn't miss anything.
And I know the answer, but just for people listening, what happens if someone lives longer than 6 months?
Thank you. I noticed that I overlooked that one, but yes, absolutely. So actually, it's one of the few Medicare benefits that as long as you continue to qualify, it is actually unlimited. Currently, I have somebody that's been on it for over 2 years. The other beautiful thing about it is that if any time, one, you decide to seek treatment, you can come off of services and then you can choose to come back on. And then also that you can graduate off of it. So we've had some people that have done better, and a lot of times that happens with the dementias. That at the time they're declining, you see, they're failing to thrive at the time, and then they get this extra support system in place, and they graduate on. I've had them do that 2 or 3 times. I had one lady on and off for about 3 years. So it is one of the few Medicare benefits that is unlimited. So thank you for asking that. So any other questions?
What about the difference between hospice and palliative care?
Good question. So palliative care is when, actually this idea is that it's a 2-year prognosis, more so. Under palliative care, you can still receive treatments, but what palliative consists of is actually typically just a nurse coming out once a month and just kind of checking in and checking to see what your plans and your goals of care are. So it's a much lighter version. It doesn't consist of all of the ongoing visits on a weekly basis. It's typically 1 to 2 times a month that they're doing a visit to.
Does it cover the DME?
Does
Hospice does no. Okay.
Typically not.
Does it cover the medications, the palliative care medications?
I believe it does. We don't provide palliative, but I believe it covers some of the medications for pain management.
Okay.
Mhm.
Thanks.
Yeah. Any other questions? Let me make sure I did. You know, and when to consider hospice is, you know, I say, especially in communities or if you know people well, you know that you can see a difference. Most people can, and just, you know, they were thriving before, now they're sleeping a lot more, that, you know, they're not engaging, they're not eating as much as they were. And we always tell people to consider it sooner more than later, because so many people come on at the last minute. You always hear people say, wish we had done it sooner. And so our agencies and others too, that will come out and check and see if they qualify. We do, follow the Medicare guidelines, make sure they qualify. But oftentimes people do, and it's you guys that notice the difference and say there is a change.
What are some common misconceptions people have about hospice?
That it's only for cancer patients. It's only for the last few days of life. Oftentimes people think that it's much too soon. They're not on hospice. And a lot of people think that they've given up. That means they've given up on them. And I always say it doesn't say you've given up on them. It's kind of like placing them in a memory care. It's saying that you want this extra support and you want to have a better quality of life till the end of life. That's how I feel. One thing that we do that's a little unique is we also do, besides the music therapies, we also do like virtual reality. And we have volunteers that go out there, and I don't know if you guys have ever done VR. So we honor end of life wishes of going on a trip, but we do it through VR. Somebody wanted to go on an airplane ride, so we took them back through virtual reality. We can do that. Take them on a hot air balloon ride. So there's different things like that that we can do to help honor them and get that best quality of life. Our our music therapists can do a lot for that as well, of creating special moments for them and their families. It's just, and you have this extra team that they can rely on to help to do that too.
Are your music therapists, is it consist of live music, or is it recorded music? Is it the patient's own music? What is it?
All of the above. They're actually therapists, so they go in there for therapeutic reasons. And so all of them have playing. They play beautiful, multiple actually, instruments. But if it's somebody that wants their own music played, they'll do that. Or a lot of times if they learn what music they like and learn the songs, and we'll come back and play them again. Like I said, we had one lady that she had dementia, that they recorded the heartbeat of her and then did a song to that and provided it to the family. Another one, I had a moment, and they just create moments. Recently a family said that, mom and dad had lived together. Our music therapist went in there and talked to dad, and he says, "Oh, you must be a baritone." And he said, "Yeah, absolutely. How did you know that?" And so then he played in baritone so he could sing along. So we sang a love song together. And then when they got done, mom got up and gave dad a kiss, and she goes, "I don't remember the last time that I saw them kiss." The daughter said that. So not only are you creating this beautiful moment of music together, but you're also creating this moment to remember it too. So that's what's important to us, is just whether it be through music or other avenues, that if we learn about that with their families, we want to create those moments. So the families always have this extra support team that's, we can help them through that process.
And just to go back to the durable medical equipment, the hospice team will bring the hospital bed and oxygen and everything and set it up where the family wants it, correct?
Absolutely, yep. And that's an ongoing process too. So yeah, and we can get it same day. So if somebody needs something, we can get it delivered the same day. So yeah, that's important.
What about after the loved one has passed? Does hospice come in and remove the equipment, or is that up to the family?
No, hospice
The
would
hospice.
be arranged to have it picked up, yes.
That's a nice thing to know.
Yeah, we try and make all that arrangement for them. But thank you for bringing that up. That I didn't touch on is that actually hospice also provides bereavement services. So all hospice agencies have a bereavement group, and that's for up to 13 months afterwards typically.
And I'll just speak to that. My husband was very briefly on Franciscan hospice service before he died, and I had a bereavement counselor afterwards. It was wonderful.
Yeah.
It was really valuable.
Good. We have different versions, especially nowadays. You know, we have some Zoom calls that people can tune into. We have it in person, also support groups or individual support groups, also or phone calls too. We can do with people. So there's lots of different ways that we try to support people because everybody's at different levels.
I was going to ask a question about support groups that were supported or sponsored by those exist?
The ones that would exist for this area, that we have them in a few in assisted livings. Right now, it would be ones that we would open to anybody you knew that needed it. It would be like a Zoom one. That we have Zoom ones that would be more than open to.
Do you provide services in assisted livings and group homes?
We do wherever they call home.
Okay.
Mm-hmm. Yep, absolutely.
And you provide services on the entire Key Peninsula?
We are. We just shared that as of last week we confirmed that we have enough staff that we can come to this area too. So, yeah. So, trying to cover all of Pierce County, even the little nooks and crannies. So that we find. You know, and that's what continue. I worked for them for 3 years, and we believe everybody deserves hospice. So we do try and do what we can to try and get to some of those more rural areas that aren't covered because people live there. That's their home. Yeah. As you know, they don't want to leave oftentimes.
And would you be so gracious as to cover a little bit of what Paula was going to talk
Yeah, I
about?
believe so. If I understood correctly, that she was going to cover the difference between what is home care and what is home health. Is that right? Yes. So I'll start with home health. Home health is typically a Medicare benefit. It's covered under Medicare. So what home health consists of is occupational therapy, physical therapy, as well as nursing services. So you have to have a need that you need one of those services. And so they actually come to wherever home is for you as well. You usually come a couple times a week. You need a doctor's order to receive them. And so they usually are 6 to 8 weeks or so that they'll be coming. And, you know, a lot of times it happens like after somebody's had a fall or, you know, some more weakness that they'll send a physical therapist out to help teach you strength training and help strengthen you. Nursing services is oftentimes maybe you might have a wound or something that might be, you know, presenting, that they'll send a nurse out for that too. So if you're eligible for nursing services too, oftentimes they might have one nursing visit as well as with the physical therapy visits. But the difference is, so that's home health, it's prescribed by your doctor, and it's covered under your insurance typically. As far as home care, many people do interchange the two. Home care is more of the having a granddaughter with you, like you were saying. Home care is having companionship at home. It is not covered under insurance. It's covered under long-term care insurance only, if you have that. That would be covered. And under Medicaid, I believe there's a few hours under home care that can be covered. But otherwise, it's private pay. To give you an idea, it's from about $30 to $50 an hour, depending on how many hours and how many days a week. But what it consists of is somebody coming to your home. They can do your cooking, your cleaning, all the way to your personal care. They can help dress, they can help showering, prepare meals, they can do the shopping. So it's just like having another, you know, a family member living with you or being with you for a few hours to be able to do those tasks, laundry, all of those types of tasks. But I think the big important part is that people don't realize that that's not covered under insurance, and so it's out of pocket. And so even combining it, so oftentimes with hospice, we're not in the home all the time, that we're there just for, you know, visits. And so a lot of times people that are at home taking care of their loved one, they'll bring home care in to help with that personal care that they need, in addition to hospice that's going to come in and help train and give the support and the items also. So does that make sense?
Is there issues that evolve over time when they have a mediset, say medications are in a prepackaged medication? The family has been helping them all along. Now the family has to leave town for another death. We had this just happen fairly recently over where I live in PL. And so the family left and they had home health care, and they came and they administered the helped administer the medication that was in the house that the family was giving, and there was a problem, something happened. And so then now there's the issue of, is that something that a home health care person should enter into, or are they prohibited from doing that?
There are home care agencies, they have to be delegated. So they have a nurse that will delegate whether their caregivers can give the medications. So there's different, they may change, and of course the price changes, whether you have somebody that's delegated to do the medications. But it is within their scope as long as they've met the criteria for that caregiver and within their organization. I don't believe all home care agencies do what we call the nurse delegation to be able to do the medications, but a lot of them do. So
And
it
the
is within
right
their
terminology is delegation.
nurse delegation.
Nurse delegation.
So they need a nurse to tell them of how to give that medication appropriately. They can't make any choices on their own. They have to have a nurse that makes that decision. Good question.
Are some of the home healthcare aides, are they LPNs or are they all just licensed caregivers?
For home care agencies, they're typically HHAs or CNAs. So either one, they can be either one, but typically not an LPN. Oftentimes they do, there's some agencies out there that actually have RNs that are on staff for like the nurse delegation and are still case managing. So you might pay a little bit more, but you know that the nurse is doing more case management of those caregivers and of your loved one too. Some home care agencies, so not all home care agencies are the same. So it depends on some of them, and you'll find a lot of times that, the less expensive ones are more there for the companionship and the laundry and those types of things, and the personal care, but they may not be able to do the nurse delegations and those types of things. So it may not have the nurse oversight as well, the case management piece.
And the home health that is covered by insurance, can you talk about how someone would qualify for that and how long they would be able to provide those services?
I'm not the expert in it, but my understanding and my experience is that you do have to have obviously a doctor saying that there is a medical need for it. So oftentimes it's weakness, and a lot of times it's due to a fall or due to a circumstance, due to a surgery. That's typically what's going to create it. But we do have people that are just declining, and so they can benefit from it. In order to continue to qualify for it, though, I do know that you have to be able to make improvements. Sometimes it's challenging for somebody that might have some cognitive loss because they don't retain it if they have to be retrained each time. And so oftentimes those people are no longer qualified because they're not retaining it. So it's not a benefit to them anymore. So that gets a little challenging at times, but
So usually it's temporary.
it is temporary. It's like
After
6 to 8
a fall
weeks.
or a hospital
Yes,
stay.
it is. And there is, I think 8 weeks is kind of on the outside. You can extend it, but most of the time it's 6 to 8 weeks that you're going to be receiving it. So, good question.
Do you still have to be homebound?
For home health, I'm trying to think, for home health, you do have to be homebound for home health. You're right.
That's I didn't know if that was still.
Yes, you do have to be homebound, not able to go into a physical therapy environment, actually into it. So yes, thank you for bringing that up. And you do have to be. But you can still go to, I know that you can go to like church or to get your prescriptions. You can do small trips, but for the most part, you are homebound to be eligible for it. Mm-hmm.
So is the criterion somewhat similar then to be in a rehab facility? You have to be showing improvement, otherwise you're moved to somewhere more permanent.
Exactly. And it's not unusual that somebody might be in a rehab and then they maximize that, but they may actually still get additional visits in the home just for maybe some occupational therapy as well. Any other questions? I do have some additional information. I give you the slides, but here's a handout. And would you consider a hospice referral? What does it look like? Kind of trigger as far as what if people are considering it. You're happy. You can bring that. And then here's another one, knowing the truth. So myths and facts, like you were saying. If you guys want one, you can pick one up as well. I'm happy to be a resource for you guys at any time, whether you go with our organization or not. And I love educating people. People have that fear of hospice, and I'm just trying to alleviate that. It's just to say, you do hear those people, you're just like, my mother's at that point of, do I continue to do chemo treatment or not? And you get to the point where I'm spending more time in a doctor's office than doing anything fun, so you kind of get on that balance. And you say, you know what, so I don't want to do that anymore. I just want to have more time doing this fun. And so once you get to that point, and you do have what may be a terminal diagnosis, it's a great, I encourage people to go down support sooner more than later. And part of that is because you can call us 24 hours a day. We have some people that will come on and we only have a nurse go out there once a week. We're meeting our criteria. But if they have a bad night, they have a bad day, they can call us and they're already on services. We're not saying, okay, let me get the paperwork, we'll catch up with you in 2 to 3 days, because that situation's happening today. We can go there in the middle of the night. It doesn't matter if they're already on services with us. I always say people never predict. We can't count on what day's going to be bad or when we're going to really need it. But if you qualify, I always encourage people to get on services, and we will meet your schedule, but it's available when we need it.
That's really empowering to have your way of looking at it. Because in a caregiver support group where we have people who have terminal loved ones, they're constantly feeling guilt because they're saying, I'm giving up if I get hospice now. And of course, the giving up is a word that we shouldn't even use in that environment, but it comes up.
Yep.
And so you don't mind being called, and you feel it's appropriate for those folks to break that barrier down and get over it. That this is something that's a natural. They're diagnosed as terminal, and so they should take advantage of it. It's better sooner than later. It's kind of the modern way of looking at this.
Absolutely, and the beautiful thing is if they change their mind at any time, they can come off. There's no repercussions. They can come back on at a later date. It extends beyond the 6 months, so there's really not a criteria around it. Anytime you seek treatment or you want to go to the hospital, you just come off the services. So it's there's not really a repercussion. Like I said.
That's really encouraging. Thank you. Wow.
I think it's very hard. Sometimes the caregiver is in a position where they're saying, yes, it's time for hospice, but the patient is feeling like, well, that means I'm going to admit that treatment isn't working and I'm dying, and I don't want to do that. Mm-hmm. And so more education on how caregivers and doctors, oncologists are very reluctant to give up, they just won't. But how caregivers and perhaps palliative care doctors and nurses could have that conversation in a more productive way with the patient, I think would be really helpful. It would just save a lot of misery.
Yeah, absolutely. I agree with that. I meet with lots of families, and I will say, once I've talked to them, most of them say, why wouldn't I do this? I call it extra support at this time. And even if there's somebody resistant, I said, we're here to support your mom, we're here to support your loved one. Is that okay if we come and help support them? To try and get them to buy off as well and understand why we're there. We're there for everybody. And so most of the time, if you explain it that way, people understand it, that they're not giving up, that it's a great benefit that they want to access.
Yeah, I think the scary thing for a lot of patients is signing the DNR and signing the agreement that they will not seek treatment. Mm-hmm. Because that's just such a huge step off a cliff in their lives. So again, more education on how to talk to people with a terminal diagnosis about that would be really helpful.
Is there any respite care during this time? Like if the caregiver...
Good question. So under hospice, there is 7 days that they're eligible for actually kind of like what he was saying, that, you know, you have a family death, that you have to go across the country. We've actually done it for caregiver burnout as well. I would like people to know what respite care looks like though, so you know what that is. So what it is that our patient will go into, we have contracts with skilled nursing environments, and so they would go into a skilled nursing for the 7 days. And so, but all hospice agencies have to provide the respite too. Good question.
Can you repeat that again? Once the hospice gives respite care for the family to leave, and that patient they're caring for goes into a skilled nursing care center with, that'd be,
For 7 days.
yeah, for 7 days. Wow.
And it's covered under hospice.
Thank you.
I know, Courtney and Idaho ended up putting in a hospice house. And is there anything like that around here?
There is a hospice house, there is one in Tacoma, it's on Bridgeport Way, Franciscan runs it. There's not many in Washington. So that's the only one, typically you really have to meet a really high criteria.
Okay.
So I like to describe that a lot of times in our state, what I experience is that if people are not able to care for their loved one at home, or they've exceeded the assisted living requirement, it's adult family homes that are really meet that need. That most adult family homes can care for them till the end of life. They have the 24-hour care there, they know how to take care of them. It's 1 to 6 if you're not familiar with an adult family home. So they really kind of fill that niche. So if I have a family member that says, I'm exhausted, I can't do it at home anymore, that's where I recommend that they go. And the nice thing about adult family homes is that, you know, they provide that care, but also a lot of them do take Medicaid. So if they have private funds, they have to pay privately for it, but otherwise if they're eligible for Medicaid, or if they're going to deplete their funds and need Medicaid, a lot of adult family homes will allow that now. But there's not a lot there's only one hospice house in this area. And they actually are fed by all of the Franciscan hospices, or hospitals, and so they run full most of the time.
Oh, okay.
Any other questions? I appreciate your time, and feel free, if you want, I can give you my cards, you guys are more than welcome to hand it out to people. I appreciate talking to families and, helping them understand and alleviate any of those fears that they might have, so.
Are your cards up there?
I will have them up here for you, yes, absolutely.
I'm wondering if it might be helpful to ask Michelle to come to one of the caregivers support groups and talk about that, but you guys can discuss that and see if you think
Just
that
ask
would be
the group
helpful.
members, and then if it's a yes.
It could be either myself or I have a coworker that's in the area, Amy, which I think is at Amy, and either one of us could, be happy to come out and just answer questions if you want, or we can do a mini presentation like this, or whatever works.
If you think
Run it
they-
by the group, see
it
what
might
they
be
say.
so.
Yeah, thank you.
Self-driving group, yeah, that's a good idea.
Happy to do that. Well, thank you for your time, I appreciate it.
Thank you, Michelle, we're really, really.